Hello, everyone. Welcome to our fourth seminar of our Frailty seminar series. My name is Olga Theou, and I'm a researcher based in Canada. I will be the moderator for today's session. Today, I have the great pleasure to introduce my colleague and well-established frailty researcher, Dr. Melissa Andrew. Dr. Andrew is a professor of medicine at Dalhousie University and a geriatrician at the QE2 Health Science Center in Halifax, Nova Scotia in Canada. She did a Master's of Public Health at the London School of Hygiene and Tropical Medicine and completed her PhD in Interdisciplinary Studies at Dalhousie University on the topic of frailty and social vulnerability among older adults. She is the principal investigator of a team studying frailty and multimorbidity in relation to dementia as part of the Canadian Consortium on Neurodegeneration in Aging. She is also co-principal investigator of the Serious Outcome Surveillance Network, where she studies how frailty impacts vaccine effectiveness, burden of disease, and clinical outcomes of infectious diseases in older adults. She's also engaged in other research collaborations, including studies of models of care for frail older adults in long-term care in relation to resident quality of life and quality of primary care. Today, she will present on frailty, vaccines, and vaccine-preventable illness. She will present for approximately 40 minutes, and then we will have approximately 20 minutes for discussion. During the presentation, feel free to add your questions to the Q&A tab that you have on your bottom or your right of your screen. Please do not use the chat function for questions. Only use the chat if you have any technical problems. So without further ado, I would like to invite Dr. Andrew to start her presentation.
Thanks so much, Olga, for that kind introduction, and to you and the organizing committee for the invitation to speak today. As was mentioned, I'll be talking today about frailty and how it relates to infections and vaccines. So I do have, as by way of disclosures, grant funding from a number of agencies and some industry partners. And have received honoraria for consulting largely around including frailty in this type of research. And am a new member of the National Advisory Committee on Immunization just as of this week. So I'm looking forward to that. So, so you may wonder, of course, this is an audience that's well versed in frailty, but often people wonder why frailty is relevant when it comes to vaccines and infections. So we'll aim to address a few different key points today, and these are the key points. So the first is that there is immunosenescence that happens with aging and with frailty, and that's associated with immune dysregulation, not necessarily just weaker immune function as it's often thought to be. And I'll give you some examples of this from influenza and from shingles. Frailty has an impact on vaccine effectiveness and vaccine efficacy, and we'll cover what the difference is between those two things and give some examples. The third key point is that vaccine preventable infections are really major drivers of complications and poor outcomes for older people in particular, but across all levels of age and frailty. And we'll think a little bit about what makes people high risk for such poor outcomes. The fourth key point is that we often consider the burden of infections just in the short term. So morbidity and mortality in the 2 weeks of an acute illness, for example. And that's in fact also often what's included in economic evaluations. But really we understand in the frailty world, perhaps better than most, that we need to think about the longer term impact of these illnesses in terms of people's quality of life and functional impairment and driving of chronic conditions, for example. And then the fifth point is really how can we aim to better consider frailty in trials, and also to promote healthy aging using vaccination. So this audience, of course, doesn't really need much of a definition of frailty, but here generally I'm referring to frailty as this vulnerability to adverse outcomes that leads people who are frail to have prolonged recovery from an acute illness and quite likely not get back to their prior baseline compared to people who are fit and more able to withstand these insults. And of course, you'll be familiar with different ways of conceptualizing frailty, some of which I'll talk to you about it in this context. So we have the frailty phenotype, of course, the clinical frailty scale, and other sort of global measures of frailty, which you'll be familiar with, of course, but has to do with largely with people's function. And then the Frailty Index, which is about accumulated deficits. And really what I'll aim to do is show you how these can be used in this setting of infection and vaccine-related research. So now to the key points. So the first one is that immunosenescence is a fact of aging and is associated with immune dysregulation. So what does that mean? So it's really interesting to think about how with aging comes changes in the immune system function. And immunologists will be able to explain this in much greater detail than I. But of course, the immune system has innate and adaptive functions. And there is this very important balance between pro-inflammatory agents and anti-inflammatory agents with the different regulatory signaling molecules. And these need to be kept in good balance. Our colleague, Jan McElhaney, who's done a lot of work on this, used to describe this as being, it's like trying to drive with the foot on the gas pedal and the brake at the same time. So it's really difficult to get a smooth ride. So this results in immunosenescence, which is the age-associated dysregulation of immune function, which can be both humoral or antibody levels and cellular related functioning. And there is this phenomenon of inflammaging, which many of you will be familiar with too, which is this chronic, low-grade, asymptomatic, but yet potentially troublesome inflammatory state that can accompany aging, and we think also frailty. So there have been a number of studies that have looked at frailty in relation to immunoglobulin titers after vaccination or after illness. And it's really quite interesting to note that really the susceptibility to illness and the immune changes that are associated with frailty are really not very well captured by measuring antibody titers, because these studies tend to show that the antibody titer response is actually reasonably good and measurable, but yet the people are still susceptible. So what's going on there? We need to understand it in a broader way. Some of work that I've been involved with Dr. McElhaney and other colleagues has shown also this issue about how the responses are more dysregulated, not weaker. So this is a complex slide, but it's just to remind me to show you that really with frailty, actually, sometimes we see higher immune responses, but the problem is that they're dysregulated and not properly targeted. So we see this in the right-hand column here, where people who were frail, according to a frailty index, had actually higher chances of mounting an immune globulin fourfold response to the high-dose flu vaccine than people who were pre-frail or not frail. So it's really kind of interesting, and it just serves as a reminder that we do not fully yet understand the immune system in relation to frailty and aging. So there are various different approaches that can be used to improve older adults' responses to vaccines, because we know older adults and frail ones in particular are very vulnerable to these infections. So we need to design vaccines that are better targeted to help them. So these are the main ways so far that have been used. So one is to increase the dose of antigen. And that has been done, for example, with the high dose influenza vaccine. And the thought there is that it better stimulates adaptive responses that might be weaker or they might be dysregulated, as we heard. The second one is to add a chemical agent like an adjuvant, which stimulates inflammation at the site of the vaccine and then enhances the ability of the responses at the site in this inflammatory milieu to mount a good response. And actually, that's one of the things we wondered in that study I just showed you, might have been accounting for higher immune responses in terms of immunoglobulins, in fact, and titers with the frail people, that they have sort of an autoadjuvant effect going on because of their inflammaging. The third thing that has been done in the vaccine world is to use recombinant antigens, so just better methods of targeting the actual antigen that's presented as part of the vaccine. And then another way that we can do this, as we're seeing now with COVID, is to give a booster dose that may help waning immune responses boost up to a higher level to start giving better protection again. Okay, so the second main point is around how frailty impacts vaccine effectiveness and vaccine efficacy, both of which very confusingly are abbreviated VE in the literature. So I'll just spend a moment to touch on the difference. So vaccine efficacy is what we see when we've got a result coming from a randomized control trial. So it's under optimal conditions in a research study, and it's generally done with objective outcomes such as lab confirmed illness. And like other measures in randomized trials, there is maximized internal validity, but you may have that happen at the expense of generalizability. And it really matters who's in the trials, of course. The other VE is vaccine effectiveness, and that's more of a real world measure, looking at observational studies done post-marketing usually to see how the protection works from these vaccines in real world settings. And often we think of these as being more clinically relevant, although of course susceptible to many biases which need to be accounted for in the studies. So I'll give you some data today of our experience with influenza and now COVID-19 surveillance in Canada with this entity called the Serious Outcomes Surveillance Network. We've been working on influenza for over a decade and now have, of course, turned to COVID-19. And I'll show you a bit of our experience with both of these. One thing that was quite unique, especially early on with this network, is that we had a focus on outcomes and measures of health that were relevant for older adults, particularly frailty, and in some seasons function and also social vulnerability. So I'll show you some of the results we've had over time. So this is relating to influenza. And it really makes the point that when we look at cases of influenza that are admitted to hospital, or people who are controls who are admitted with similar case definitions of acute respiratory illness but don't have influenza, that's who's enrolled in this network. So here with the influenza cases, we see if we stratify by age, that as people get older, they're more likely to have been vaccinated. Not surprising because a lot of the messaging, especially historically, has been targeted to high-risk groups, older people. If you have conditions and your age is older, you should get vaccinated. So the vaccine uptake is higher. We also, of course, know that the outcomes tend to be worse as we get older. No surprise there. Interestingly, we always see that the intensive care unit admission decreases with age, and that has to do with goals of care discussions, because of course it's not that they have less severe illness, it's just that they're more likely to die without having gone to the intensive care unit. When we look at this stratified by frailty, which is of course of interest today, we see a similar but even stronger impact, right? So older people who are more frail tend to be more highly vaccinated. They tend to have even worse outcomes than we see when stratified by age. And also less intensive care unit admissions at the higher levels of frailty. So the main message here is that it's quite important to take frailty into account when we're thinking about vaccine effectiveness for older adults, because if we don't adjust for this fact that they're more likely to be vaccinated and more likely to have poor outcomes, we'll underestimate vaccine effectiveness for the general older adult population. And so the way that we calculate vaccine effectiveness in that study and in many other observational studies is through a test negative case control design. And really what we have is all of these people are patients admitted to hospital or meeting the same case definitions. We divide them into cases who have confirmed illness. In this case, influenza, could be COVID, could be whatever we're looking for vaccine effectiveness. And then the controls are the people who do not have the illness, do not have an influenza, but we see who's been vaccinated. So they're the ones that are in the darker color. And then we're able to calculate a vaccine effectiveness in this way. So here's an example from a season where we looked at this in detail in that Canadian network. So overall, for adults over 65, if we don't adjust for anything, we saw a vaccine effectiveness of 45% preventing against hospital admission, which is moderate, fairly good. It's good to prevent 45% of these admissions. Once we adjusted for all the factors, including frailty, that went up to 58%, which is quite an impressive difference. And the point is not the detail of how much it went up or changed, but the point really is that what we found in that study was adjusting for frailty alone was very close to the final full adjusted model. So if you want to pick one thing to consider when you're looking at vaccine effectiveness for older adults, frailty would be that thing. Another way that we can look at these results is to stratify by frailty. And so when we do so, we see that the vaccine effectiveness is actually quite high for people who are non-frail, or this is at a pre-frail. These are based on cut points of the Frailty Index still. But for the people who are the most frail, the vaccine effectiveness does tend to go down. And this is where we have that paradox that, you know, these are the people that are most in need of protection, but they have the lower vaccine effectiveness from current vaccine products. And what we need to do is improve coverage to get as many of these people vaccinated as possible, but also improve the vaccines themselves. The other key message there is that most older adults are not frail, so they actually have very good potential to respond to vaccines. So the public health messaging needs to take that into account so that we don't lump all older people together saying, oh, the vaccines don't work as well for them. Well, in fact, they do work very well for the subset of people who are non-frail to perhaps mildly frail. So that's important to take into account. We can look at this sort of moderate vaccine effectiveness as a glass half empty or glass half full. So when we did this across multiple seasons, we noticed a few different things. So each season is different in terms of the influenza viruses that are circulating and how well the vaccines are matched. But generally speaking, what we see is that there are some differences by age. So younger adults may tend to have higher vaccine effectiveness, but not always, depends on the season. And that we generally see higher vaccine effectiveness against the more severe outcomes, which now we're starting to understand better with COVID as well. So that's really hammering that point home. So here's another example where we tried to apply this concept of frailty and a frailty measure to our large randomized control trial, in this case, of the shingles vaccine. So the recombinant zoster vaccine was studied in these very large randomized control trials called the Zoe 50 and Zoe 70 studies. And they showed a very high vaccine efficacy in the prevention of shingles. And what we wondered was whether we could use the data that was already collected in the course of those studies to generate a frailty index, and then to study, first of all, were frail people included in this trial, because we know often they're not. And then also, what was the vaccine efficacy against in the prevention of shingles, and what were the antibody and cell-mediated immune responses stratified by frailty, and what was the safety and reactogenicity profile like. And I'll add here too that there are not very many geriatricians and frailty interested researchers who've been involved in vaccinology, but certainly Ken Schmader is one who many of you will know, especially those who are US based, and he was involved in this study and was really great to meet him in that capacity. So what we did was generate a frailty index based on the data that were already collected in the course of that big study, including medical history, the quality of life questionnaires that were done at baseline and follow-up to generate, pain and functioning, mental health. And we put them together into a frailty index for the purposes of showing differences between categories. We stratified, but of course, a frailty index is continuous and you can use it that way as well. So what we were able to discover was that there were some frail older people who were included in these studies, which is interesting. The frailty is the darkest group here, the frail group, and up to 22% of the over 80-year-olds were frail. So that was one thing that was interesting. The second thing, when we looked at vaccine efficacy stratified by frailty, we found that it was actually quite high, still over 90% for the frail group, which is promising. The immune responses with antibodies and also cell-mediated immunity were actually quite robust, even across the grades of frailty. And interestingly, reactogenicity, so that's the side effects that you get right at the time of a vaccine, so like the red arm, sore arm, fever, feeling fatigued and whatnot, was actually lower in the frail people compared to the non-frail people. So that's kind of interesting. And that's the orange bars here are the people who received the vaccine. So you can see how that was, it's a very reactogenic vaccine, these shingles vaccines are, but it was less so with the frail people. So better tolerated in the frail, perhaps because of these changed immune responses. And there was no safety signal in relation to the vaccine in any of the frailty groups. Of course, there's more what they call adverse events in a frail group anyway, but it didn't have any relationship with the vaccine status. So from that study, we were able to conclude that the vaccine efficacy was quite excellent across the grades of frailty. There were some frail people who were included in the study. For the purposes of today's discussion, that it is possible in many cases to generate a frailty measure, particularly a frailty index, where it's more flexible in terms of what's included, retrospectively using data that are already collected. So that means that we can include frailty in some clinical studies without increasing participant burden or cost. We're hoping to apply that same concept in COVID and are working with one of the big COVID vaccine studies to try to do that. But those data are not available yet. So now turning to the third point, which is really near and dear to what a lot of us are trying to do here, demonstrate that the outcomes are really relevant to consider over a longer period of time. And we need to consider frailty when we're thinking about who's getting these poor outcomes. So we know, of course, about the burden of COVID. That's very high worldwide, with millions of cases and, thousands and thousands of deaths. And these are just numbers from Canada, but, around the world, of course, we hear about these every day in the news. We shouldn't forget that influenza has a great burden of illness and hospital admission and deaths on a yearly basis. These are, again, just Canadian numbers. So each infection has a list of high-risk conditions. So according to the World Health Organization, this is the influenza high-risk list. So that anybody can be affected, but some groups are more at risk than others. And these include pregnant people, young people, older people, people with chronic medical conditions, and also immunosuppressed people and healthcare workers. So it's kind of interesting to think, how do we conceptualize high risk, and can frailty be helpful to us in that way? So taking a step back, who is at high risk for influenza and for COVID? Is it higher attack rates? For example, people living in congregate living situations such as care homes? Is it people with poor immune responses, both to the vaccine, so they get lower protection, and to the illness? Is it because older people who are frail may have suboptimally recognized and treated illness, and that has to do with atypical presentations? So they don't meet case definitions for surveillance. They may not then be picked up as a case, and they may not be appropriately put on precautions and treated. Is it because of poor outcomes, both in short and long term? So is it because they have more susceptibility to worsening or triggering of other medical conditions or persistent functional decline? Or is it really, as I would argue, all of these things that go into making people high risk for these infections? So looking again at influenza, and you can see similar things for other conditions, particularly COVID, we're understanding more and more the indirect health effects of COVID and long COVID, for example. But for influenza, where this has been studied over many years, we know that There are direct effects on respiratory systems, such as asthma, COPD exacerbations. Some of the work from our network that I showed you earlier has showed that really about a third of COPD exacerbations in flu season are because of influenza. And we're much better at thinking about giving them antibiotics than we are anti-influenza agents. So we need to change that thinking. Of course, it can trigger superimposed bacterial pneumonias as well. But there are these indirect impacts on other organ systems, which are quite interesting. So influenza has been shown to be a major trigger of heart attacks, angina, strokes, delirium, of course, as this audience would be very familiar with. Also falls and fractures because people are sick and then they fall. And then it can also exacerbate various conditions like diabetes, kidney disease, and as we're now beginning to see, frailty. So thinking back to this, as well as to what I just talked about, like what makes people high risk, along with other colleagues, I was doing some thinking about, why is it that people in long-term care facilities and homes are more vulnerable to COVID-19? And really it becomes a combination of all these factors, but it's quite interesting to consider this on like a multi-level or ecological type framework. So at the level of the individual, these people living in nursing homes are frail, they have chronic conditions, they present atypically, they may present just with delirium with no fever or cough, and so it's harder to recognize their illness upfront. There is an important reliance on families and caregivers. They get isolated, their advocates don't see the change in them to trigger a workup for delirium. They live in close quarters in these institutional settings. There may be limited resources, particularly compared to acute care settings. Staffing models can be unfortunately limited, with limited numbers of staff or staff who only work part-time or in casual jobs. So they're working in many different facilities or different jobs and then come in exposing across facilities. There may not be sick leave policy. And then at the level of the health systems and services, the funding is often lower and seen as lower priority versus acute care. In communities, these facilities may be isolated and or they may be located, or the staff may come from community clusters because of socioeconomic factors in the area. And then at a policy level, there's many policy considerations regarding how much testing is done and what resources are there. So there's a very interesting work that's been done on this through the pandemic, much of it published in the LTC COVID website. But I just urge you to think about this at the multiple levels, not just the frailty, but all the things that surround the frail individual. So here's some data that we've found with frailty in relation to COVID-19 admissions in our Canadian network. So these were the first 2,000 or so patients admitted in Canada in 2020. So really the first wave up to the second wave of the pandemic, and before there was much in the way of vaccination available. Interestingly, we looked at frailty in all ages, not just older people. Of course, when we consider older adults over 65, more of them are frail. So as the colors get darker here, the frailty is higher according to the clinical frailty scale. But of course, we'll know that younger people can be frail too. And although 43% of these younger adults were not frail, we had about an equivalent percentage who were quite frail, even at these younger ages. So we also, similar to what I showed you with influenza before, we see that older age and frailty are both independent predictors of more mortality and less ICU use in COVID-19. So here's the graph by age. So death is presented as the blue bars here. So of course, there's much more mortality. Almost 30% of those over 85 died if they were admitted to hospital with COVID, but there was less ICU admissions, as shown in the red. When we stratify by level of frailty, we see a similar pattern, but even perhaps more pronounced, so that the mortality was approaching 40% for the most frail, and the ICU admissions went down quite a lot. Now, looking at another condition that's vaccine preventable, this is pneumococcus. We know that pneumococcal illness, invasive pneumococcal disease, and pneumonia are very important drivers of morbidity and admissions to hospital, particularly for older adults. So we've been looking at pneumococcal pneumonia and illness in our network as well. And just a couple of things to show here. So what we found was that patients admitted to hospital with pneumococcal confirmed pneumonia tended to be younger and less frail than non-pneumococcal. But interestingly, the vaccine coverage, of course, tends to be higher in the people who are older and sicker. And similar to what we saw before with the differences when we stratify by age and frailty, there's a trend toward higher vaccination at older ages. There's also higher mortality at older ages, shown in the green bars here versus the green bars in the 65 to 74 age group. And there tends to be a bit less intensive care use. But interestingly, we do find that there was more ICU admission in the pneumococcal disease than the non-pneumococcal pneumonias, which does suggest that there is still some important room to be, or for improvement in terms of vaccine coverage and vaccine effectiveness to try to help prevent some of these admissions and deaths. When we stratify by frailty, we see a similar impact, in fact, that there's higher vaccination among the most frail and higher deaths among the most frail. So part of why people may do more poorly when it comes to these infections, and part of why we have a suboptimal understanding of the full burden and the number of people who are getting these infections, is that they don't always meet the case criteria. So we did another study here looking at how well the case definitions for influenza-like illness and severe acute respiratory illness work at older versus younger age groups and also across levels of frailty. So the ILI case definition requires a fever and cough. And the main difference is that the SARI case definition doesn't require a measured fever, but it's just more of a feverishness and is hospitalized. But in this case, what we're showing here is all hospitalized individuals. So what we found is that for older adults, the ILI case definition only had a sensitivity of about 44% for people admitted to hospital with lab confirmed influenza. So if you stick to fever and cough, you miss more than half of older people admitted to hospital with influenza. Relaxing the definition of the fever just a little bit does help. So that gets you over 50%, up to 57% sensitivity. And what I've put here for no high risk is compared to a younger person without a high risk condition. So really it makes us think about what case definitions we're using in surveillance and treatment protocols too. So the fourth thing is the outcomes of infections are often considered over only the short term, and we need to think long term as well. So I'll just show you a graphic that captures what we've been seeing in our network over the years. So what we see here is 100 older adults coming into hospital, being admitted with influenza or an acute respiratory illness, which might have been vaccine preventable. Fortunately, we have 68 of them who are surviving and can leave hospital with preserved function. Unfortunately, 12 of them will have died during the hospital stay. And we have 20 here who suffer a functional decline. About 9 of them have a moderate functional decline that's measurable and clinically meaningful, and it's not back to their baseline, but it's not catastrophic. But these 11 have had a catastrophic functional decline, meaning that they now need help with 2 or more basic activities of daily living. And even some of them, 3 of them out of the 100 that we started with, will end up having to go to a nursing home when they didn't come from one. So we really need to think of this burden of persistent functional decline and long-term care, and these people who, even if they go home into the community, need more help from formal and informal care services to really understand the full burden of influenza. It's not just about these people who died and the people, the time spent in the hospital. So we've done some surveys to try to understand this a bit better among community dwelling older adults. This particular one studied over 5,000 older adults who live in the community and have internet access. So, tend to be better off and more highly functional perhaps than the general population. But they were older with a mean age of 71. And most of them are not frail. So only about 8% were vulnerable and 2% frail. But interestingly, what we found was that of the people who reported having had influenza in the year before, 20 of them, 20% or 1 in 5 were unable to function to their usual standard during the acute illness. And many of them didn't recover within the usual 2-week period that we think of. And some of them never fully recovered. And we can all think of people that in your own life, who were doing well, functioning in the community, took a hit such as influenza, and then never quite got back to their prior baseline. We did another version of this survey more recently in 2020, so getting into the pandemic era, and found that for the age group 50 to 64 versus those over 65, there was an important, of course, impact of people having influenza and being absent from work and missing work, but also they were missing volunteering. 44% of these older adults were missing volunteering, missing caregiving activities. And this one is particularly troublesome, is these are the people who had no other option but continued to provide care to a vulnerable older or younger person while they were sick with this infectious illness, 47% of them. And the impacts can last quite long. So up to 30 days of missed employment or providing suboptimal care. So it's really important that we think about the impacts on other aspects of people's lives as well. So just to summarize what we've come so far, it's really critical that we understand frailty in relation to identifying infections and measuring the effectiveness of vaccines and considering their outcomes. And we need to really understand the impact on frailty and function to understand the true burden of these illnesses. So this brings us to the concluding section. So how can we avoid frailty and what can we really do about it? So I've mentioned a bit about what vaccine trials assess. They look at efficacy in the setting of a clinical trial. They tend to look at immunogenicity, reactogenicity, and safety. But do they include frail people? Because they're the ones who are arguably at highest risk of the infection and need the protection the most. So vaccine trials, just as a reminder, work in phases and generally have healthy volunteers until you get into phase 4, which is the community-based post-marketing surveillance. Now, some phase 3 trials do include a range of health status and frailty, as I showed you with the shingles trial. But that's relatively uncommon. Many of these studies, as you would have seen the protocols, do tend to have a lot of exclusions. Frailty has not often been considered when it comes to vaccine-related work. And this isn't any sort of systematic review. This is my own sort of considered review of the literature, looking for the studies that I could identify. So what I saw was that there are various frailty measures that have been used: Frailty Index, scale phenotype, modified phenotype, which is important because a lot of people in hospital can't walk, for example, so you'd have to use a different measure of gait speed. Then the Edmonton Frailty Scale and grip strength. Frailty-related conditions or indicators is particularly commonly used in claims data or like big data, secondary data analysis of administrative data. There can be some use of propensity scoring to try to understand differences between who gets, say, one flu vaccine versus another flu vaccine. And then some functional measures as well. So just to describe a few examples. So the Frailty Index has been used in interventional studies, both prospectively with pneumococcus. There was only one study that I found. It was done about 10 or more years ago. And then also an influenza vaccine study in the mouse model, interestingly, used the Frailty Index. I told you about the retrospective shingles, flu, and COVID studies that have used Frailty Index already. And then in terms of observational studies, it's been used prospectively in some networks, like I mentioned, like the SOS network that I told you about. It's been used looking at immune responses in relation to the frailty levels by Frailty Index in a long-term care setting study. And in an interesting study about avoidance behavior, so like avoiding contact with other people and whatnot according to one's frailty level. So I won't go through all the details, but what I'll just say is that it's a relatively sparsely populated table and suggests that we really need more inclusion of frailty in these sorts of studies. And in some of them, actually, they're used as an exclusion. So their frailty scale was used in one of the COVID studies as an exclusion. Anybody who scored highly on the frailty scale was excluded. They didn't really define what that was that I saw. And then the frailty phenotype was used as a descriptor in an influenza vaccine study, but again, not as a measure itself. So there's much work to be done there. And the reason that there's much work to be done is if we think of the example of COVID, so who were the first people to get the COVID vaccine? Well, they were, 90-plus-year-olds living in care homes. And were there any 90-plus-year-olds living in care homes who were in the studies? Well, no, as it happens, there weren't. So, it's really important that we consider that type of thing when we're looking at who we're trying to protect. So these are some general collected thoughts that I've, kind of pondered. So we know that the vulnerability to illness and adverse outcomes means that older people are an important target population for vaccines. However, we know that vaccine effectiveness is often lower. And maybe frailty accounts for much of this, but hasn't usually been considered, which is unfortunate. Interestingly, people may worry that you give a vaccine to someone who's already vulnerable, and does that in and of itself cause a problem for their health? And fortunately, the people who are frail tend to have lower reactogenicity and tolerate the vaccines better, which can be reassuring. We know that there is this change in immune responses with immunosenescence. We have yet to understand the full ramifications of that in relation to frailty. And that led me to really thinking about what is the role of geriatricians in all of this. So this is a review or discussion piece that I wrote with colleagues, including Ken Rockwood and Ken Schmader, who I mentioned, thinking about how really at every single one of these stages of vaccine design, of the product itself, how you design the trial, who's included, who's excluded, how you define illness in the trials, how you monitor safety, how you measure outcomes, what analysis methods you use, and then how the regulatory and advisory committees will interpret these results. What kind of surveillance we do once they're out in the world in real world use, and then how we communicate in relation to program implementation. Really, we need people with frailty and geriatrics expertise at really all of these levels. So to put it all together, I showed you this sort of ecological model of vulnerability to COVID in care homes. And this is another version of that, where it's just a very high level perspective saying, when it comes to critical incidents, we have these various levels of protection to protect a frail person from injury. And the problems happen when the upstream levels do not protect them, when the holes in the Swiss cheese all line up, right? So you've got a person who's frail, they have themselves, therefore, bigger holes in their Swiss cheese, if you want to think about it that way. They're more susceptible to persistent outcomes, functional decline beyond the acute phase. They have more complications of illness. They present atypically, so they don't get diagnosed and treated as well. They're more likely to be exposed because of living in congregate living settings and having caregivers. And they have the suboptimal vaccine responses. And then, of course, like you can think of the bigger upstream policy related things too, in terms of how we value older people in long-term care settings, for example. So we have to think about all these layers of protection, including how well the vaccines work and how many vaccines get into people who are frail. So we think of the accumulation of deficits with frailty that can happen as people get older. What we often, unfortunately, see is that people accumulate health insults, they get more frail. But what we try to do is to flip that around. How can we use this knowledge about frailty in relation to vaccines and vaccine preventable illness and vaccine preventable disability to try to improve people's health over the lifespan? And so this is an example of the Canadian Frailty Network's work on Avoid Frailty. So these are the 5 things that they've been promoting to promote healthy aging and frailty reduction. And one of them is vaccination. So I'll leave you with that thought. Thank you so much for your interest. And these are acknowledgements of colleagues and funders. And in particular, I dedicate this session with gratitude to Jan McElhaney. Happy to take any questions.
Thank you so much, Melissa, for an excellent and very timely presentation. Our audience is already submitting questions, so I'll start with the first one. Earlier in your talk, you spoke about how vaccines are effective for older adults. Do nursing home residents continue to be especially vulnerable to COVID-19 since vaccine administration?
Yeah, it's a very good question. I think and there's studies that are looking at this, and what we can do is compare the waves of COVID. And we've done this in our network. I didn't show you the results where I'm just presenting them at a conference tomorrow. In fact, looking at the different waves. So one thing we see is that with wave 1 and 2, before we had the vaccines, we had a lot of older, frail people being admitted to hospital and many more nursing home outbreaks. In the third wave, what we saw was a reduction in frailty and in age of people admitted to hospital. We think because the older people had higher vaccine uptake and were more protected, and there were fewer outbreaks happening in nursing homes. Another thing that we haven't dwelled on today yet, though, is changes or the persistence of vaccine protection. And I have seen some really interesting findings that show that the waning of immune response to COVID vaccines is particularly relevant for the oldest age groups and for presumably frail people, although I don't think it's been well studied in relation to frailty. So this is where many jurisdictions are getting into boosting giving booster doses to people living in long-term care settings. So to sum that up, I think that the vaccines have done a good job in protecting vulnerable people, particularly living in long-term care and where there's been high vaccine uptake. But we do need to maintain that level of protection, probably with boosters.
Would you say frail older people require a different vaccine dose for better results?
Yeah, that is a great question. And, that's another argument for why frail people really should be included in studies at earlier phases, even when they're looking at the dose finding, because we have seen that the influenza vaccine that has a higher dose of the antigen, it has 4 times the dose, does have benefit in terms of efficacy in trials and what looks like effectiveness in the real world as well, compared to a regular dose for people who are older and frail. And so it may be that some of these other vaccines would be better. It would be better to have a higher dose for people who are older and frail, but we just don't know that because they haven't been studied with that lens. I mean, certainly we see with the COVID vaccines that they're using a lower dose for kids, and maybe eventually we might end up with higher dose for older people. We don't know. At least I don't know that.
A lot of our vaccines are one and done, like shingles and PPSV23, and meant to provide protection for decades. Is there any sense if frailty is associated with loss of protection over these long periods of time?
Yes, I would love to know that. And I think, again, it speaks to the importance of including frailty in the studies that are looking at that. We saw in the shingles vaccine study that we had good good vaccine efficacy upfront within the time period of the study. And it'll be interesting to see, with that study and with others, how long that lasts. And whether we need eventually to have different guidance from the technical advisory committees in each country and jurisdiction to say, if somebody is a certain level of frailty, should we give them a booster dose or use a different product? But that's really in its infancy now. But I think there's more awareness now, particularly with the pandemic of COVID, that's hopefully going to bring that to people's attention.
is there a particular component of frailty that you think is most influential on vaccine response?
That is a good question. I guess it would depend how we measured and thought about frailty. To date, I think there's not enough evidence to go picking apart, which part of frailty or what contributors are the ones that are particularly important. I mean, certainly we know from other studies that some immune compromising conditions may be more relevant than non-immune compromising conditions, but I guess would come from a background thinking of frailty as quite a holistic measure. So I'm not sure that we'll get too far by trying to pick it apart. I think we are better off thinking about it holistically, getting it into use in however we measure it, getting it into use in studies, and then see what we learn from there.
Thanks. Can you postulate why frail people are excluded from vaccine trials?
Yeah. I think it's not unique to vaccine trials. I think it's the case with other clinical trials, especially the large ones of, say, like cardiovascular medications and whatnot. What they try to do in those trials, which are complex, is to try to simplify things as much as possible. So they want to get rid of anybody who might have another reason for having a poor outcome, or who might respond to the medication or the vaccine in a different way, like kidney function or liver function or whatever. So what you do typically see if you read the protocols for these trials in detail is a very long list of exclusion criteria, so that they get down to the purest, healthiest people that they can possibly use in the trial. And it's also then, in general, it'd be easier for volunteers who are more mobile and less vulnerable in terms of their health. One thing that I do recognize for sure with the COVID trials is that they were done during the first and second waves of the pandemic, when there was a lot of fear and messaging for vulnerable people to shelter in place and not leave your house. And so of course going to participate in a trial involves leaving your house, and so that would have impacted on recruitment. But so in general, the reasons that people are excluded from trials are just so numerous. Where we can start is having perhaps a more open mind, thinking that this is the real world. We're going to need to represent these people, and there's going to be more and more awareness of decision makers, clinicians, and people themselves to say, do the results of this trial apply to me or my population? And if those people are frail, they want to see representation in the trials.
Thank you. The audience can add questions in the Q&A function.
May I ask a question?
Yeah, sure, go ahead.
Thank you, Melissa, for a great presentation. We know that vitamin D deficiency is common in older adults with frailty. In fact, there are associations between vitamin D deficiency and the onset of frailty. The question is, there's some mentioning in the literature about the role of vitamin D to enhance immunogenicity and maybe vaccine effectiveness. I'd like to get your comments on that, and whether it will be important to recommend the determination on vitamin D deficiency in older adults or those that are frail.
I think that's a great question. And again, not something that I have seen studied enough. Certainly makes sense to optimize people's health as much as possible to optimize their potential for responding to vaccines. And so if there's a signal that vitamin D may help that could be very helpful. It's an easy thing to do. I was in another discussion group recently where somebody said, perhaps, we could think about the role of sarcopenia. And the relationship between bone health and frailty, and maybe there is an impact on like the bone marrow responses as part of the immune system. And we really, I don't think we know that very well, but it's another thing that really should be studied. There are studies now that are looking at immune responses in relation to frailty. We're involved in some based out of our center in the context of a large nursing home outbreak, and also in the context of people being exposed and having COVID-19 illness, but also pre and post vaccination, to try to understand how frailty impacts the vaccine responses. So there is going to be more that's coming out, but we need even more of these studies to be done.
Thank you.
also have a question. Do age and frailty explain almost all variants in vaccine response, or what is missing from that equation?
Yeah, I think it's a good question. I don't think that they will explain everything. I mean, they certainly can, as we saw, like when you adjust for frailty in these observational studies, you can see, some improvements in vaccine effectiveness. We still have a number of other issues. Probably we have yet to see optimally targeted or designed vaccines to perfectly stimulate the immune system. I mean, definitely we're getting closer, with the over 90% efficacy that we've seen with the COVID vaccines with the mRNA platform. So that may, so the design may explain some of the variability, and also there's other factors, no doubt, that we have yet to understand.
And what can we learn from the last 1-2 years with COVID-19 that we can also carry forward, hopefully with either influenza or other infections?
Yeah, I mean, I guess a couple big things are the importance of including this concept of frailty and the lens of frailty at every step, like I showed you with that sort of roadmap. That's relevant for COVID vaccines, but it's relevant for all other vaccines too. And then another thing, I guess, is that we need to, and then a part of that is including people in trials and getting data that have to do with frailty. And another thing is really to understand, people are much more aware of vaccines than they ever were, I would argue. And to really understand that there are really big benefits of vaccines and improving vaccine coverage to promote healthy aging across the life course. So hopefully some of that will translate into the post-COVID era, if we ever get to a post-COVID era.
How does your knowledge of immunosenescence translate to your clinical practice when you're treating a frail or not frail patients in clinic or in patients?
Oh, that's a good question. So one thing is to be very alert to the atypical presentations. I mean, we know this in the geriatrics literature that people present atypically with everything. They present atypically with heart attacks and they present atypically with influenza. I think what's been interesting over the decade or more that I've been involved in this world is that that's less well recognized in the public health and infection communities. And so understanding that we need to have perhaps a lower bar or a greater index of suspicion to recognize people who may, maybe this person in front of me with delirium in the emergency department has influenza or has COVID. I mean, that's one thing that's interesting is we're recognizing now how many asymptomatic people of any age there can be with COVID. So perhaps we're a little bit farther ahead there, but we still have yet to incorporate this knowledge into case definitions for surveillance, for example. And I guess another thing is with the immunosenescence, just understanding that they may need, well, they definitely need attention to vaccines as part of healthy aging. And I do try to incorporate that into, my discussions with patients in the clinic and in patients to see, have they had their vaccines in an inpatient setting? Can we give them to them while they're there, before they go home, or at least recommend that their primary care clinician gives them their vaccines. To try to hammer home that message about how it's really about optimal aging. It's not even, sometimes people, may underestimate the importance of an infection like the flu or pneumonia, but when they think about it in terms of their own independence, then they may be more likely to take the vaccine. So I guess the immunosenescence comes into play in some ways as a specific concept, but more generally, it's more just about like the vulnerability and the atypical presentations that would be there.
Thank you so much. And I think with this question, we'll finish our session. Thank you so much, Melissa, for your presentation, and thanks to the audience for the questions. You will all receive a short survey after the end of this presentation. Please fill it out, and also don't forget to register for our next session on January 12th. We have an exciting panel discussing about frailty indices based on electronic healthcare record data. And our panelists will be Dr. Andrew Clegg from UK, Dr. Ariella Orgabi from US, and Dr. Nicholas Pajeski also from US. So on behalf of the organizing committee, I would like to wish you a relaxing and enjoyable holiday break. This past year has been one for the books, so we hope you have an amazing new year. Stay safe and healthy, and thank you for attending our seminars. Thanks, everyone.
Thank you.
Melissa.